Hello, hello, hello. Greetings, everyone, and welcome back to the 18th Indoanesthesia 2021 Week 2. I would like to say good morning from Jakarta, and I would like to welcome all the registrants. I think until this morning, we have more than 3,000 registrants already coming from more than 70 countries. I've seen several countries registrants from many I think South American country. Hello, greetings from Jakarta. And so to start this morning, we will have three sessions. The first one is about obstetric anesthesia. I think this is one of the highest, the most interesting topics in the fields of anesthesia because many of us will face obstetric cases. And to start today, we will have three prominent speakers. We will have see Dr. Brandon Carvalho from USA. Thank you for staying up with us. I know it's late in there. Professor Alexia from Singapore and Dr. Chan Kuen from Malaysia. And this session will be led by the one and only Professor Made Wiryana from Bali. Prof. Made?
Okay. Thank you, Annie Marie, thank you very much. And good morning, ladies and gentlemen, to all participants of the Indo-Anesthesia Symposium, especially our honorable speakers in this session. I'm Made Wiryana as a chairperson in this session. This session will be focused on obstetric anesthesia, analgesia. And this session will be addressed by three speakers, expert speakers from abroad, from USA, Singapore, and Malaysia. And we will inform to all the speakers, the time for presentation will be 25 minutes each speaker. And at the question and answer in this session will be held at the end of this session. We will start the session and we invite Dr. Brandon Carvalho from USA. Dr. Brandon, we will talk about technique to optimize your labor epidural analgesia. Please, Dr. Bernard Carvalho, time is yours. I'm remembering you 25 minutes. Thank you.
Well, good morning, everyone. Hello, Jakarta.
Good morning, Doctor.
Well, it's an absolute pleasure to be here, and I'm really sorry that I can't be there in person because of the pandemic. And I'm here to share you my experience of how we optimize labor analgesia in our setting where I work at Stanford University in the United States. I want to highlight two main areas. First, I'm going to talk about optimal insertion technique and highlight three very important techniques that work well for us, both ultrasound guidance, combined spinal epidural or CSE, and a dural puncture epidural or DPE technique. I'm then going to move to maintenance techniques and talk about patient-controlled epidural analgesia, program intermittent epidural boluses, and then local anesthetic solutions. Now, why am I recommending ultrasound placement? Well, actually, if you compare studies, and there's lots of studies combined with meta-analysis, data suggests the risk ratio decreases significantly for technical failures. You decrease needle insertions, both increasing first pass success and decreasing redirects, and actually save a little bit of time with the actual insertion part. And there's actually, interestingly, evidence to suggest improved analgesia after using ultrasound when you insert your labor epidural. Now, why is this the case? Well, generally, when we use landmark-based techniques, we tend to be too high. and it works well for first stage of labor, but not well for the second stage of labor. And this was an interesting study that actually deliberately put epidurals at L1-2, which we often are doing when we just use landmarks, compared to L4-5 using ultrasound. And they found it worked well in first stage of labor, but the lower placement worked significantly better in late labor. Another reason why we think it works better is you're more likely to have midline placement if you're using a device that shows you where true midline is, especially in patients with difficult palpation. There is actually some data to suggest you may improve the safety, decrease traumatic placements, that's blood, either at the spinal needle or for epidurals at the TUI needle. You trend towards less back pain, probably because of less insertion needle passes. And there is still no data suggesting it decreases dural puncture. This would require thousands of patients, and we probably will never have that data. But there is some theoretical reason why it may decrease risk, partly because we don't go as high as we would without ultrasound, and because of less needle insertions. And these two theoretical reasons would suggest it is a safer option. Now, obviously, for normal backs, we often don't really need ultrasound help, but for difficult block placements, we certainly can do with the help. And it's estimated that approximately 4% of blocks are difficult. And with difficult blocks, there is an association with increased complications, both increased dural punctures as well as more neurological problems. It is an incredibly easy technique to use. We have the ultrasound probe and the machine because we are using it for the baby. It's a technique that a number of videos, SOAP has a nice one as well, where you use a parasagittal oblique view to determine your interspace, flip the probe to determine the optimal interspace, measure depth, and then mark it off. So it's a pre-procedure technique. It's incredibly easy technique to learn. The next is not a new technique. It's combined spinal epidural, but it's a technique that is not utilized enough, in my opinion. It is a standard epidural, but sticking the spinal needle further into the spinal space to elicit cerebrospinal fluid and administer a drug. When it was first described, I think almost 25 years ago, Rachel Collis's group in the UK, the blue line in the graph shows just how incredibly effectively and quickly a CSE worked. And this was sort of a game changer in those times, especially because it also allowed mobilization, and the true mobile epidural was born with a CSE technique. There have been many studies since comparing the two techniques. The theme that we see with most studies is a quicker onset, which can be up to 30 minutes in advanced labor, but in early labor, obviously significantly less than that. But what is not truly appreciated is that you get better subsequent functioning after your CSE, less sacral sparing, less one-sided blocks, and fewer block failures. And why this is important is obviously we don't want blocks to not work, but we also want to pick them up earlier if they don't work. This is a very interesting study that looked at data from Wake Forest, where they estimated their failure rate was 6.6% with CSEs versus 11.6%. It was a high number, but it's obviously how you define block failures. But what's interesting with the study is not that there was twice the incidence with epidural, but that the catheter was significantly quicker recognized to be failing, because you expect a CSE to work well. So if it's not working almost immediately, you start questioning if your epidural is placed correctly. Another interesting study that shows the utility of a CSE technique, specifically getting CSF, was this study that was a study that was studying the effect of the CSE, but in patients who did not get a CSF after attempting a CSE, they still threaded the catheter because they had good loss resistance, and they treated it as an epidural. And they found that the failure rate with the CSE when they got CSF was 4%, but when they were attempting a CSE technique but didn't get CSF but continued with the epidural, had a 29% failure, again showing that determining midline, getting a little hole in the dura with your spinal technique with the CSE is very important for good ongoing functioning. And it not only works in labor, it's significantly more likely to work when you top it up for a cesarean delivery. Estimated odds ratio of 5-fold increase with significantly less failures for cesarean anesthesia. So all round, we like this technique and we utilize it in over 50% of our patients. Now, there are side effects, drug-related side effects. If you take pain away quickly, there is a high incidence of fetal bradycardia, and it's the well-known phenomenon. It's easily treated if it were to occur. You get pruritus from the opioid, hypotension from the local anesthetic, and a lot of theoretical risks that haven't really been realized. Infection because you're piercing a dura or some neurological complications. What I find sort of interesting is all these theoretical risks haven't been realized, and I would have thought you would have seen a higher dural puncture incidence because you're doing two techniques. You're doing a loss resistance with a TUI that is common with an epidural, but you are then piercing the spinal fluid with the spinal needle. But interestingly, most studies show either lower incidence or the same incidence. And this is probably because more experienced people or specialists are doing CSEs, or because when you do get a loss resistance that you're not convinced about, you're more likely to check and confirm with a spinal needle rather than advancing your TUI needle. I mentioned how well they work. So the theoretical concern about an untested epidural catheter has not been realized because generally they work a lot better than a standard epidural. Now, a newer technique, which is being contemplated to be utilized more frequently, if not take over from an epidural, is a dural puncture epidural, which is essentially a CSE technique, but without dosing. So you get loss resistance like a normal epidural, place your spinal needle, confirm CSF flow, but take your needle out without dosing any medication. And the first studies from Brigham were actually quite impressive. But importantly, they were using a 25 gauge needle, and it seems like you need a certain size orifice for this effect to work well. They showed you quicker onset of labor, about 20%, less sacral sparing, and fewer one-sided blocks. The same benefits I showed you with a CSE, probably again because you're confirming midline and you're making a hole in the dura, and this is common to both CSEs and DPE techniques. Now, we now have 5 studies. There's actually a systematic review that compared DPE to epidural. And unfortunately, 2 out of the 3 studies are from Brigham. 3 out of the 5 studies are from Brigham. And the benefits have been demonstrated there with larger gauge needle, but haven't been realized in other institutions. And overall, the data is weak that it makes a significant difference. So we don't routinely use this instead of an epidural. I'll discuss when we select to use a DPE technique. Fortunately, it hasn't been shown to be more associated with more complications. And a lot of the outcomes we would care about, like block replacement, or intravascular catheters, headaches, and hypertension, on no difference have been found in a systematic review. So the authors in this systematic review said we still require evidence whether a DPE is superior to a standard epidural. Now, there is one study that have compared the 3 techniques, epidural, DPE, and CSE. And I want to highlight this before I move on to maintenance techniques. And this is an extremely important study because it compares the 3 techniques back to back. And we see very clearly in red the CSE technique showing much quicker onset, 2-minute median time, compared to 11 with DPE and 18. So DPE was slightly shorter median time than epidurals. But what is important also to notice is that the interquartile range is very narrow with CSEs, whereas they are wide up to 120 minutes with both DPE and CSE. In other words, you expect the CSE to work quickly, you want it to work quickly, and you don't mess around. It should work quickly, and you move on. DPEs, you can see sometimes for 120 minutes of struggling before replacing it. So this study, to me, demonstrates unequivocally if you need quick onset, CSE is the technique. The study went on further to compare some of the other benefits. As is mentioned again, DPE versus epidural shows less sacral sparing one-sided block. And obviously, because you're not giving a drug, DPE has less pruritus, less hypertension, and the less uterine hypertonus and fetal bradycardia. So in settings where you don't need quick onset, perhaps a DPE is better. So when do you choose and what should you use? It's really up to individual centers to decide. We do CSEs in any advanced labor situation, provided fetal heart rate looks reassuring. We reserve DPE for patients that we really are not sure if we get good loss resistance or difficult palpation, or you needing to do redirects to find your loss resistance, just to confirm midline placement. So essentially we are doing a DPE technique in there. And in patient which you want slightly quicker onset, but you have a non-reassuring fetal heart rate, we don't do a CSE technique. And epidurals are for the rest of the patients. So it's in our center about 50% at CSEs, about 10% DPEs, and 40% epidurals. All right, moving on to maintenance. There's a number of techniques that are described. It originally started with just manual boluses, but when we had the pumps to give infusions, that's what we used. Interestingly, manual boluses worked very well, but they were extremely labor intensive. So fortunately, pumps now that can do patient-controlled epidural analgesia, PCEA, or program intermittent boluses are getting the benefits of a bolus technique without the workload and all the problems associated with manual bolusing. So if you compare PCEA to continuous epidural infusions, what you see across the board is significant less local anesthetic use. Estimated to be about a quarter to a half local anesthetic use, and with less local anesthetic, you have less motor block. And improved analgesia, partially because of the bolus technique and also because of the woman's autonomy and satisfaction related to being able to self-administer and not wait on physician boluses. And physicians are happy because it significantly reduces our workload, around 20% reduction of callbacks or top-ups. It is better, however, to do a PCA with a background infusion because you get called back less, and this is what's been shown in a number of studies. You get better analgesia, allowing a woman to sleep, so she doesn't have to keep pressing the button to get pain relief. The problem is that if you give too much background infusion, you do have to be careful because you start to negate some of the benefits with using more local anesthetic. So based on this data, suggesting a better background infusion, you should have a background infusion, but probably what is better is to have a background PIEB or program intermittent bolus technique. And we'll run through the science behind why you should all be using PIEB. So the first data came from cadaver studies showing much better spread if you look at giving a bolus under high pressure with larger volumes. And a very simple dye study showing in the bottom right-hand corner how much better spread you get with an intermittent bolus technique compared to a continuous slow infusion. And so this is the key behind why we think it works better. And if you look at animal models, looking at the same bolus versus continuous infusion, you get much better segmental spread up the neuraxial space with the higher pressure boluses from your PIEB or intermittent bolus technique. So lots of good animal and human cadaver data. So does it work in humans in a clinical practice? And there's quite a bit of data out there. This is the first meta-analysis that Ron George did, showing less local anesthetic use, higher maternal satisfaction, and a trend towards a shorter stage of labor and less instrumental delivery. So we were hopeful that a few more studies would push it over to show that PIEB actually improves obstetric outcomes. Unfortunately, that wasn't the case. Alex Sear's group did a meta-analysis more recently, again confirming it works better with less local anesthetic use and high maternal satisfaction. But the instrumental delivery rate, duration of labor, and cesarean section, though there's a trend still favoring PIEB, doesn't seem to be different, at least with this set of data. So it is a better technique, be it marginally and probably not affecting obstetric outcomes. Now, we changed practice several years ago. We were actually the first in the United States to do so, and we immediately found it made a difference to our practice. We were being called back less, 19% versus 12%. We had less one-sided blocks, and generally patients were happier. Now, we already practice a fairly good neuroaxial technique for labor, so the difference was very small for us. But you can certainly see much bigger differences in practices and make bigger changes. And I wanted to highlight this because this is truly impressive. If you want to continue using just a continuous infusion of a high dose, like the study started out at 0.2% ropivacaine, continuous infusion, but they made 3 swaps. They changed to PIEB and PCEA instead of continuous infusion and halved their local anesthetic concentration. And by doing that, they decreased their ropivacaine use and had significantly less motor block. In fact, 31-fold difference. And that equated to better patient outcomes and shorter stages of labor. So you can truly make a difference by instituting these technique changes. If you are interested in changing over, I'd encourage you to read an article that ANA was very kind in allowing us to do, because it was more an implementation piece, which goes more into technical challenges and things to think through as you are changing over to the technique. And this is from a learning curve for both our institution and Ron George's. I can tell you very quickly from a PCEA versus PIEB point of view, there is no perfect recipe, and there's lots of little play arounds you have to do. Generally with PCEA, you want as large a bolus as you can, but you want to stay within safe limits. And if your lockout is too long, that's problematic. So you need to find the balance between a large bolus that's safe and doesn't require too long a lockout. For PIEB, Jose Carvalho's group has done interesting ED90 studies suggesting a 40-minute is the optimal lockout and an 11 ml bolus in their settings using 0.065 bupivacaine. If you do use PIEB or a bolus-based technique, I strongly encourage you not to check sensory level, because the vast majority of women will have blocks above T6. And if you stop their infusion, they will report pain fairly soon afterwards. So the only thing you should monitor is motor block. You should eliminate motor block. So motor block is what we monitor. We do not care about sensory levels because they go very high with dilute solutions and bolus-based techniques. Now, I've been focusing a lot about the techniques and bolus-based techniques, but what is most important before you even think of using any of these techniques is to add an opioid to your solution to use more dilute solution. And this was work that was done in the 80s, but has been shown in multiple studies since that you can reduce your motor block from almost every other woman experiencing it to very few. So we have a handful of patients that will experience significant motor block using 0.065% bupivacaine with fentanyl. So strongly encourage you to use dilute solution. And if you want to see some obstetric evidence of benefit of using dilute solutions, we did a meta-analysis a few years ago showing that you can significantly decrease assisted vaginal delivery, which is our primary outcome, using solutions less than 0.1% bupivacaine or equivalent with ropivacaine versus heavier solutions. And with that, we also found shorter second stage of labor, less motor block, and improved ambulation, and most importantly, without affecting analgesia. So you do not compromise your analgesia, and you can improve your outcomes. And an interesting study that in a way complements this, if you use low-dose epidural and you compare it to non-epidural techniques, this meta-analysis showed that you actually have no difference in obstetric outcomes. So a well-managed epidural with dilute solutions and carefully managed technique can actually work as well, it will have as few effects as not receiving an epidural, but a heavy one may affect obstetric outcomes. And if you are using an epidural, you can continue it all the way through a second stage of labor, all the way through to repairing after the baby is delivered if you require it. There are a number of studies showing this, and a more recent large study of 400 patients continuing a dilute solution all the way through second stage of labor made no difference to the spontaneous vaginal delivery rates. All right, so in summary, when you approach neuroaxial analgesia for labor, the key is obviously to take away pain, but do it at the least amount of local anesthetic. So everything has to be focused towards trying to minimize local anesthetic use. With that, you'll get less motor block. You will improve your obstetric outcomes when we'll be able to feel the contractions, push more effectively, have shorter second stages of labor, and more likely to deliver vaginally. So how do you do this? Well, the first thing you have to do is you add neuroaxial opioid. By adding neuroaxial opioid, you can significantly half or a third the amount of local anesthetic is needed. And with that, you have a larger volume. And the key is you need that increased volume, because when you have a larger volume, bolus-based techniques become effective. If you're using concentrated small boluses, a PCEA or a PIEB technique is less effective. You need the volume. At Stanford, this is our recipe. It's not a perfect recipe. It's what we've developed over the years. We're a little heavy on the CSE because, again, we use it in late labor. If you're using it for all patients, you can certainly give less if you feel you require it. And then in terms of the PIEB and PCA settings, we do 9 mLs every 45 minutes. You probably can get as low as 8, but no lower, at least in our experience, before there's diminishing benefits from that. We give a large PCEA bolus, and we actually give it very frequently, 10 mLs every 10 minutes. Now, the reason behind this is the PCA affects the PIEB setting, so we don't want to delay the natural background of PIEB. So if a woman requires a supplementation, we want to give it to her. And obviously, after you've done your initial block, you want to delay the pump to start around 30 minutes. We feel if we wait longer, it doesn't kick in enough when the initial bolus has worn off. All right, so the techniques I've described are what is outlined in the Centers of Excellence. I'll strongly encourage good centers in Singapore and elsewhere to apply for this, to have recognition for the good care that you provide. And it emphasizes CSEs, low concentrations, ideally less than 0.1%, the use of neuroaxial opioids, as I mentioned, and possibly some adjuvants if you're having difficulty controlling pain. And PCEA with ideally PIEB in the background. Future Centers of Excellence will start insisting on PIEB as a maintenance technique. I thank you very much for your time. I'm happy to field questions when all the panelists have finished chatting. And just to remind you that the SOAP meeting is going to be virtual as well this year. So feel free to join, and I look forward to questioning in a few minutes. So thank you very much. You need a mute.
Prof. Made, boleh di-unmute, Prof?
Thank you very much, Dr. Bernard Carvalho, for your nice presentations. And Dr. Bernard Carvalho tell us about the ultrasound guidance for CSA or epidural to have precise injection, to minimize injury, quicker onset, and superior analgesia. And then a lot of study about the advantage or disadvantage of continuous or control or bolus of local analgesia drugs. Once again, thank you very much, Dr. Bernard Carvalho. And then we continue for the second speaker. We invite Dr. Anelgesia. Dr. Anelgesia from Singapore. Dr. Anelgesia will talk about labor analgesia in the year of 2021. Please, Dr. Anelgesia, time is yours. And once again, I'm remembering that your time, 25 minutes. Time is yours, Dr. Anelgesia. Please.
Hi. Good morning, ladies and gentlemen. Thank you very much, Dr. Made, for that very kind introduction. And really want to thank Dr. Stilo and the organizing committee as well for this invitation and this opportunity to talk to you about some of the work that we have done in KK Hospital. Unfortunately, this year, we are doing this via Zoom, but I hope that we'll be able to meet one another soon hopefully next year. Please do give me a bit of time to get this screen. Are you able to see my screen?
Yeah, but not in the full screen mode. So in the PowerPoint view.
Yes.
Yeah.
Okay.
Okay. Okay.
Okay.
How about now?
It's okay, Dr. Alexia. It's okay.
Okay. Thanks. Thank you so much. So selamat pagi.
Selamat
Ibu,
pagi, Dr. Alexia.
Bapak-bapak yang dihormati. Diharap kesemuanya dalam keadaan yang sihat dan walafiat, dan diharap dapat berjumpa lagi ya secepat mungkin. Okay. Thank you very much. Yes. So, you know, some of you may be happy to know that this morning I will not be talking about COVID. Instead, I would like to take a more sort of a futuristic look at the possibilities, a little bit of optimism perhaps of what would be possible for labor analgesia as we move forward in the next decade. Many of you will know that I work at the KK Women's and Children's Hospital. The good note is that in spite of COVID, we didn't see a reduction in the number of deliveries. And KK Hospital, of course, is the largest maternity hospital in Singapore. And we hope that moving ahead with the lockdowns and with families and couples spending more time together, we will see an increase in the number of deliveries. It's wonderful to come after Brandon. In fact, I would say it's very hard and easy to come after Brandon in this webinar. Hard because it's difficult to top Brandon's presentation, and he's such a wonderful speaker, and I've learned so much from Brandon. On the other hand, it's so easy because he has said everything that I wanted to say. So my job is just to basically to continue on the work that or the presentation that he has made. But essentially, what's not new is that labor pain is still one of the most painful experiences, and untreated labor pain is harmful. It is not innocuous, and it has repercussions both on the mother as well as the neonate. And a neuraxial block, an epidural, is the gold standard in managing labor pain. As an obstetric anesthetist, our holy grail is to be able to provide a seamless, safe, customized analgesia with minimal motor blockade and side effects. And as in all things in medicine, provision of labor analgesia has to take into consideration shared decision-making with the patients and the family. And it has to be done respectfully, and the work that we do has to be responsive to individual patient preferences. In other words, we need to continue to change our conversation from what's the matter with the patient to what really matters to the patient. And when we provide labor analgesia, the patient has to be the front and center of everything that we do, including the induction of analgesia and the maintenance, as well as the whole journey of the process of labor and delivery. And of course, we need to strike a balance, right? We have to maximize benefits to our patients and sort of minimize and manage all the risks associated with the provision of pain relief. And as a corollary, the use of low concentration, high volume analgesics, this area has been so clearly alluded to by Brandon anymore, so I will not belabor the point anymore, but essentially we need to achieve a balanced approach that would be able to maximize the beneficial effects for all our patients. Control is, of course, a very important element. Again, Brandon has spoken extensively about this. So having patient-controlled epidural analgesia is the preferred technique, the gold standard in the maintenance of pain relief during labor. And PCA, or patient-controlled epidural analgesia, with a background infusion is currently the recommended technique because it is able to improve analgesia, is able to improve maternal satisfaction, as well as reducing the need for anesthetic intervention, and with that, a minimization or optimization of side effects. So this is quite indisputable. And in fact, during labor, after a successful induction of analgesia, background infusion may not always be necessary because if it has been done successfully. However, as labor progresses and pain intensifies and extensifies, a background maintenance dose would be necessary. And indeed, it does make sense to have a variable background maintenance dose, which is responsive to the patient's needs. And for the rest of this presentation, I will just make 3 points or make 3 suggestions for all your consideration. The first consideration is actually quite intuitive, and it is that labor pain is dynamic and progressive, and there's no one-size-fits-all prescriptive approach. In our computer integration work, we found that the ability to vary the background infusion actually generates a lot of value for our patients. We are still looking at coming out of the system. Unfortunately, COVID-19 has been a dampener in this, and we look forward to hopefully enabling this technique in the near future. Second suggestion that I would like to make is what's been talked about by Brendan earlier as well, and that's a background infusion for the maintenance of analgesia is important. And when we first started using PCA, we used to do that without a background infusion. So it's quite clear that you would need a background infusion. And it is also conclusively shown that it's perhaps better to give a continual to provide continual boluses than a continuous infusion. In other words, the rate of injection does matter. And Dr. Carvalho has talked about the mechanism behind it, so I will not belabor the point. And there's a lot of evidence that's shown, for example, some of these studies that we have done, as well as previously performed in a head-to-head comparison between a continuous interventive and a continuous infusion. They have shown that the use of PIP or automated mandatory boluses could improve analgesia, improve satisfaction, as well as possibly reducing side effects to the parturients. And the use of continual boluses in conjunction with patient-controlled epidural analgesia as well, we have also shown that PIP, or the use of automated mandatory boluses, could reduce the use of local anesthetics, improve analgesia, as well as enhance patient satisfaction. The third point that I would like to make is that it's actually more of a question that we are now living in an era that perhaps gives us the opportunity to design a therapeutic predictive decision support system that's better able to provide real-time personalized analgesia. In other words, with the ability to do real-time data analytics, we could possibly be able to come up with a decision support system that would be able to provide seamless and optimal analgesia for all our parturients. And perhaps let us start with the induction of analgesia. And this study that was done some time ago showed looked at learning curves for anesthetic procedures performed, and the authors reported that epidural anesthesia was perhaps one of the most difficult procedures to perform. And in this more recent study, the authors reported that one would need something like 30 to 50 procedures for epidural to gain competency. So in other words, a novice epiduralist will need to do it about 30 to 50 times before he could gain mastery. Put it in another way, we could potentially put some 30 to 50 women at risk in order for an anesthetist to become good at the technique. It is no wonder that I remember my professor telling me that if you have not had an accidental dural puncture in your training, you would be either not telling the truth or you haven't done enough, or both. So is that necessary? Right? In this paper that I managed to dig out, and it's apologize, it's a little bit outdated, and this is Embrace report from the UK. The good news is that the incidence of death due to anesthesia was clearly on a downward trend. However, in that triennium, the 4 deaths due to anesthesia were all deemed to be preventable. And half of them, 2 out of 4, were due to accidental dural puncture and its sequelae. So having an accidental dural puncture is not just inconvenient because of the headache, but it potentially could also put our patients really in harm's way. So there are certainly gaps in the way we do it at the epidural block. I'm so happy that Brandon talked about the use of ultrasound. Indeed, I agree that the use of ultrasound is something that would definitely generate value for all our patients moving ahead. However, at this current point in time, the most commonly used technique is what we call the palpation technique, and it has many shortcomings that I will not elaborate. The ultrasound is touted to be the solution in many ways. However, it does have issues of its own, and I'm not sure about the rest of you, but I face many challenges in learning to recognize many of the features. So in the hope of narrowing the gap, we actually did machine learning and train our system to by using what we call a support vector machine to extract, to match the detect and using AI to classify the images so that we are able to ease the learning curve for all our novice anesthetists. And of course, the aim is to for us to come up with an automated ultrasound guidance system that will be able to optimize entry point as well as to optimize the depth of the needle placement. This work is still at its infancy, but it's shown some promise. So I will beg your indulgence to show you 2 very short video clips in the work that's gone in this area. And so the way you do the procedure, the ultrasonography is actually not different than without this program. So the key feature of this technique is to identify the sacrum. And in this preliminary work, we are looking at L3-4, but certainly it could be programmed to look at L4-5 as well. So the first part of this study is to identify the sacrum, after which it could be programmed to guide the user to identify L3-4 in space, after which it is marked. And this is, of course, followed immediately by using a transverse view to identify the midline and also, importantly, to determine the depth of the epidural space, so that the point of entry could be completely demarcated for the procedure. In our preliminary study results, we found that the use of this automated system was able to improve the success of a first needle attempt to 92% in the normal patient and to some 79% in patients with higher BMI. And the whole procedure would take largely less than a minute, and there was a strong correlation between the program reported depth and the clinician measured depth of the epidural space. And of course, our hope is that we will be able to use this as an educational and training tool so that we are able to increase the capability of hospitals to manage challenging patients. We hope to democratize skill acquisition, in other words, to ease the learning curve and with that, a reduction in training time so that we would reduce stress to both our trainees as well as to the patients. Another way that data analytics could help us is in the area of the maintenance of labor analgesia. So in this analysis that we did a few years ago, looking at about 280 women who underwent labor analgesia with our computer integrated PCA, we found that about 10% of the women had breakthrough pain. So also one of the events that could undermine the satisfaction of the woman who experiences labor analgesia is incident of breakthrough pain. And in this study, we found that several factors, such as a low successful to total PCA demand ratio, as well as the high BMI, could be predictive of breakthrough pain. And breakthrough pain itself could be unsurprisingly predictive of poor satisfaction, as well as the risk of dysfunctional labor, sometimes needing intervention, including cesarean section. And a high incidence of breakthrough pain could also, again, very logically, predict the need for epidural resiting. So the question really is are we able now to pool all the data together in a very real-time manner so that we are able to come up with an interactive system that would be able to provide treatment or very customized treatment for our patients. For example, to predict breakthrough pain before it happens, to tell us when an epidural catheter could be recited before it's too late, and also to enable us to perform interventions in a very proactive manner. Indeed, I think we are taking baby steps towards that direction. And even though the use of machine learning and data, as well as pattern recognition in this paper that we published recently, we believe is one of the first in obstetric anesthesia, did not show any further advantages in comparison with the conventional statistical method. We have to caveat this because the reliability of the system is truly dependent on not just the accuracy of the data, but also the precision as well as the timeliness of the data. So if we have real-time data, right, then it could be very different. And secondly, the etiology of breakthrough pain is also multifactorial. And therefore, if we are able to provide real-time data, and we have now the ability to do that because we're talking about real-time, we are talking about real current, hourly rate of use of local anesthetics, the timely or the real-time distance between two demand doses of PCAA, as well as the on the dot ratio of the demand, the total demand versus the successful doses given via PCA. All these data with the currently available neural network, we will be able to provide a real-time pain relief for our patients. And of course, work is ongoing, and we completely agree with this editorial that says that it's too early to rule out, the use of machine learning in obstetric anesthesia. So with that, I submit to you, ladies and gentlemen, this is my summary slide, that labor pain is an extremely subjective and constantly evolving experience. And there is certainly no one-size-fits-all epidural. PCA is, of course, the gold standard for the maintenance of neuraxial block. So having a bespoke background dose would generate value for our patients. The use of automated intermittent boluses, it is recommended in comparison with the continuous infusion in the maintenance of neuraxial block. And by doing so, we'll be able to effect drug sparing as well as to reduce instrumental delivery. And finally, technology-driven refinement of smart delivery systems can enable excellent holistic and compassionate care. And I may add, not expensively in the days to come. And we hope by doing so, we will be able to improve safety, efficacy, efficiency, and the individualization of care. So with that, I would like to acknowledge my team of co-workers and partners, as well as our funders, and also my declaration of interest and ownership of intellectual property in this area. As such, the content of my presentation has to be taken in that light. And again, I really want to thank all of you for your kind attention, and I really wish everyone the best of health always, and I hope to see everyone again. Thank you very much, and back to you, Dr. Made.
Thank you, Dr. Alexia, for your nice information for us and how to use ultrasound and computerized integrated for labor in Parturient patient. It is a very informative information for us in our field in my profession of anesthesiologist. Thank you once again, Dr. Alexia. And then we will continue for the third speakers. We invite Dr. Chan Yu Kuen from Malaysia. Dr. Chan Yu Kuen will be talk about optimizing spinal anesthesia for the Parturient patient. I'm remembering, Dr. Chan Yu Kuen, your time is 25 minutes. Please, time is yours.
Thank you. Thank you, Professor Made, and thank you, Prof. Susilo as well, and team for the honor of this invitation to speak. And I'm trying to control my slides. Shall I go back to my first slide first? Can you all see my slides?
Yes, Doctor.
You can, but I don't seem to be able to move my slides backwards. Just a minute.
You may try to use the keyboard.
All right, okay. So I'm going to share some thoughts on how we can optimize spinal anesthesia for the Parturient. And the running title is to understand the technique and the drug, where I'm going to focus my main lecture on. All right. And do I have a conflict of interest? Yes. This has been sponsored previously by Aspen. And if you do not know who or what company Aspen is, it is actually a company that has taken over from AstraZeneca with regards to the use of the local anesthetic Ropi and bupivacaine. So I work, or I've retired mainly, but I come mainly from the Women's and Children's Wing of the hospital, University Malaya Medical Center. And I intend to look at this lecture focusing on how spinal anesthesia has become the predominant form of anesthesia in obstetrics, and how, like the two previous speakers, pain is actually also a consideration where spinal anesthesia is concerned. And when a patient has pain, it's equivalent to the awareness under general anesthesia we used to talk about. So pain is the equivalent of awareness under regional anesthesia. And as I said, I'm going to look at focusing this lecture on how to make spinals work 100%. And of course, also how to optimize it for the obese patient and other challenged patients in our practice. You will realize that obstetric anesthesia is now dominated by the use of regional anesthesia and mainly spinal. And this trend actually started about 20 to 30 years ago in the West, in the advanced countries, but there's also a rising trend in the developing countries of adopting this technique. And what I have here is actually data from Nigeria. And as you can see, general anesthesia has dropped in use and regional anesthesia has begun going up. Now, does regional anesthesia offer better anesthesia for the obstetric patient? We are also actually affected by the presence of pain in anesthesia, and in this particular survey or study or claims that actually shows what is picked up from the American closed claim analysis for obstetric and non-obstetric cases between 1980 and 1999, where there was rising trend, of course, in the use of neuraxial anesthesia for the obstetric population. And you will see that up to 11% of the claims in the obstetric providers were due to inadequate anesthesia and analgesia. So there's actually a substantial number of claims for that. And this slide shows what AstraZeneca kept as their annual reports of failed spinals in the company. Of course, this is the rising trend, as you can see, from complaints from Asia. And I personally remember having made 2 complaints of drug failure or accusing the drug of having failed me in my junior years. But of course, now that I'm more mature, I have begun not to accuse anybody, and I believe that I must accuse myself for any failure before I accuse others of being responsible. And that philosophy has actually helped me in the last 15 to 20 years. And why so? Because it has allowed me to learn and to really look again and re-look actually at the technique and the drugs that we use. Well, let's look at the spine of the obstetric patient, and you will see like that, similar to the non-obstetric patient, this is the curvature of the spine. And if you look at what the obstetric patient has to experience, especially with the baby in front and the weight in front, the lordosis is very much more emphasized. And the idea is you actually have to put your spinal in L3, L4, and this is actually pushing into the convex part of the spine, and it's not easy. So most of us make huge attempts to open up the spine. If you don't ask for the spine to be opened up and allow the extension to occur in the usual posture of the mother, you will find that the opening is extremely small. But if you actually are able to flex it, you will find the opening is a lot bigger, can even be about near twice the original size. So how do we actually get the patient to flex the spine? in our country, or rather in my institution, we give a beach ball to the mother to hug so that it distracts her as well, because then she will imagine she's relaxed actually at the beach. And when she hugs it, she actually tends to flex her back as well. And the provider, in addition, would ask or would put a thumb near the site that maybe at L4, L5, L3, L4 spine, and ask her to use that spinous process to push against the thumb. You must be very specific, because she should not be pushing with the other parts of the body, but specifically with the spine, L3, L4 spine, against the thumb that is now presented to her back. And by doing that, she actually flexes a lot more. As I said, the bull's eye is actually very big. It can be up to about 2 centimeters. I have actually looked at the spine, I mean the skeleton myself, and realized that it is actually very big. The problem is a lot of us sabotage ourselves. And why so? Although we say that when we do our spinal, we should go for the midline comes with the spinous processes in the way. So if you ever have any difficulty getting into the spine, into the intrathecal space, please just move yourself about 0.5 centimeters away from the midline, and you will find that the space you will be shown or you will be allotted by the mom is actually a lot better. So the para midline is a lot better if you have difficulty. And of course, well, most of us may sit our patients up, but there are many of us as well who actually lie the patient in the horizontal position like so. Please do remember as well, the female and the male spines are different. And if you have actually a rigid bed or the OT table, and you allow your patient to lie down for the spinous injection, you will find that the spine actually slopes down this way, because for the female anatomy, this part is usually gynecoid, and this part actually is of a wider diameter compared to the upper portion of the patient. So be mindful of that as well. And it is very important, well, for us in Malaysia, we tend to sit the patient up. Whatever, when you actually put the spinal needle in, it is important to ensure that your spinal needle stays steady. That means you actually insert with a introducer and then you put the spinal needle in, but at all times, especially with a mother in pain who has just come in for an emergency cesarean section, obviously had been laboring in labor ward and would be getting the pain every 3 minutes. It is important to be steady and use your hands optimally to steady your spinal needle as well as the introducer against the patient's back, like what this person is actually doing. And even when you are injecting or aspirating, continue that process, because I normally find a lot of trainees not anchoring their hands or steadying the needle, especially the needle that holds the conduit to allow the injections to go in against the patient. Now, you only inject in the presence of free flow and excellent aspiration. I can't emphasize this often enough, because when you actually do your spinal, you must always have a mind map of where the outflow part is. It has to be totally in the intrathecal space to allow free flow as well as to allow good, adequate aspiration. I actually find it very amusing when my trainees tell me they can actually feel the various layers like how you would feel the various layers with an epidural. But for all intents and purposes, because these spinal needles are usually about 25 to 27 gauge, you cannot feel anything. But once you are in the midline or near midline, you know that you will hit something solid. And that something solid can be into the bones or even into the posterior longitudinal ligament. So when I ask my colleagues or my junior colleagues and say, okay, so how do you know you are actually in? Well, without being able to figure out where you are in terms of how you feel the epidural space, the ligamentum flavum, you will never know. But you actually, when you hit something, a lot of my trainees assume that they have hit bones and they will take it out. But they never question that, especially if they are in the midline, that they could possibly be in the posterior longitudinal ligament. That means right into the intrathecal space. So I would advise that, especially if your needle is far in enough, you should withdraw slowly to allow the CSF to actually exit. And you will find that most times it does come out. Because if you had prematurely pulled it out with the understanding that it has hit bones, when it has actually hit the posterior longitudinal ligament, you are giving yourself a loss. That's a lost opportunity for you. A truly intrathecal injection that will allow the CSF to come out, but you have pulled it out prematurely, thinking that you are in the wrong space, but you were in the correct space. And just be patient, the CSF will come out, you aspirate, there will be free, good flow. And that's the time, hold on to the needle against the patient's back and inject. All right, but when the flow is not free, it can partially be in the intrathecal space and actually be partially out as well. In fact, this is a more detailed one. So it can be partially, as I say, in the intrathecal space, but it can be elsewhere as well. That means it can be in the epidural. Some parts of it may be in the epidural space. So if you inject at this juncture where there is no free flow, inadequate free flow, or inadequate aspiration, a lot of the drugs will be lost here. Your patient will not have adequate doses in the intrathecal space, and you're going to have a failed spinal for the patient. Now, as I said earlier, if you had totally been in the midline or near midline and hit something, come out gently and use that as the site for injection. Now, sometimes, as I said, you are here, you aspirate, you get the flow, and there's a suggestion there is flow, but it's not free. When it's not free flowing, please push the needle right back again. Of course, you put the stylet back in and push it back, and then do what I advised earlier, come out gently. And then when there's free flow, you aspirate well, and that's the time to put the injectate right in. When I was actually in the Philippines speaking about spinals, I was actually very indeed surprised by the fact that the whole country actually does it in the lying down position, whereas in Malaysia, we tend to do in the upright position. Anyway, there was this particular study by a junior colleague of mine doing it with me. We were comparing the CSF flow between the lateral decubitus and the sitting position, and it's very important, especially for those of us who are doing it in the lateral decubitus position, to note that the flow coming out is actually very much slower compared to the sitting position, because with the sitting position, you have got the weight of the column of CSF pushing the fluids or the CSF out. So the flow will be a lot faster. Now, those of you who practice the lateral position, the question is, do you want to position and perform the spinal in the left lateral or right lateral? Again, this question was posed, and it's again very amusing that a lot of the providers will say they will opt for a left lateral position. And this is the challenge that was actually taken up by Ian Russell, no doubt. in 1987, but it was, in my opinion, a very good study. So he subjected 35 women to these two positions for elective cesarean section. And he found that the mean segmental level versus time, as you can see here, was no different between the two groups. So it does not provide very much for the answer. However, he noted that those who were placed in the right-sided position while the spinal was being performed required no further analgesia or top-up, whereas those in the left-sided position, when the spinal was inserted, 5 patients needed postural manipulation to encourage the spread. And in fact, even 2 required supplementary analgesia. So he re-looked at his data, and as you can see here, he redivided his 2 groups of patients, regardless of how they were done in terms of position, as to whether they needed intervention or no intervention. And he found that as early as 2 minutes, he could already pick up that there was a difference in onset time between those who needed intervention as well as those who did not need intervention. By 2 minutes, those who were not needing intervention had already reached a level of T8, whereas those who needed intervention were still languishing at a level of L2. And I'm sure a lot of us share this experience as well. And we tend to wait and wait and wait. And after that, we will declare that it is a failed spinal. And I'm going to share 2 stories of failed, one of failed spinal and another of inevitant spinal, where I learned further about spinals and how to meet the challenge of providing a good spinal. So I, in my practice as well, do private practice. So obviously I'm frontline with these patients. And here there was this 33-year-old lady needing a spinal or needing a cesarean section. And my obstetrician advised me, after having chatted with the patient, that I had caused a failed spinal in her 2 years previously. So I looked at the notes, and actually I had faithfully recorded that there was more pain on the right side. I had offered general anesthesia, but she declined, and I had given her Entonox as the substitute. So when I saw her, I discussed with her the issue, and I offered to allow her to change the anesthetists, but she declined. So I had then to take up the challenge of accepting the fact that it might become still another failed spinal, but I told myself it's an opportunity to make sure I put all my knowledge together and help her. So what I did was I gave her more fentanyl than our usual 15 microgram. I gave her 20. And remember, she had a failed, the pain was more on the right side because it was a sitting position. I had put her down. I turned her more to the left previously, and the pain was more on the right side. And by the way, we use heavy bupivacaine. So I decided I was not going to tilt her for a longer time until the drugs had a chance to act on the right side as well. So more fentanyl, longer position in the supine position, and it became a superb spinal for her. And in the end, both husband and she felt that I should be the person doing her next spinal if she chooses to have one for her next cesarean section. And this is another interesting one where I learned, as I said, more about spinals. Again, this was a private patient who requested for an epidural, and she was actually in pain. I would put the pain at about a VAS score of about 6 to 7. So 10 minutes after I've given the test dose of 1.7 mils of 0.75% ropivacaine, she said her labor pain was totally relieved, but she was still able to move her lower limbs. Suspecting that I had an inevident spinal, I omitted the first top up, and I continued with an infusion of 2 ml of 0.1% ropivacaine with 2 microgram per ml of fentanyl, and I placed her in the left tilt. And because I had already arranged a prior meeting with a lawyer about something, I had to leave her under the care of a senior medical officer, and I told him what to expect, that it was an inadvertent spinal. He had to watch the patient like a hawk. And 1 hour later, he came back to me and said, Prof. YK, I think your epidural catheter has gone to the right side, because the patient is now complaining of more pain on the left side, but no pain on her right side. So I looked at the medical officer and I said, no, it's something to do with the drug. So what I did was I actually turned the patient onto her right side, because her complaint was pain on the left side, and I have caused a spinal. And this was actually an infusion of a hypobaric solution, if you can understand here, which I'm going to be elaborating on in a short while. So here I have a hypobaric solution, and the drugs were moving to the, she was actually placed on the left side, and the drugs were actually floating up onto her right side. So that's why her right side was pain-free. So I actually now asked for her to be turned completely to the right side so that the drugs would now float to the left side. And indeed, it completely relieved her of her pain. So that brings us to the question of not only knowing your technique, but of knowing your drugs as well, because a lot of us do not understand our drugs very well and how it can actually make matters better or make matters worse. And as you can see here, there's a definition of density, SG, and varicity. Density is when you're comparing weight against volume. Specific gravity is when you're comparing density against water. And varicity is when you're comparing against density or specific gravity against CSF. So you would notice that we tend to talk about varicity. That means all our drugs, whether it is hypobaric, isobaric, or hyperbaric. Obviously, when we do spinals, we use hyperbaric because we want the drugs to move downwards. And it is very, and they will stay together as well and give you the dense block that you need. So it's very important to understand the difference between all these drugs and what you are using at all times. All right, so we have all the 3 definitions. And the question now is, how much drugs do you want to use for all your patients? Because a lot of us grapple with tall patients, short patients, and we always tend to give very much lower doses for our shorter patients. And then before we know it, we are in trouble. And I tend actually to advise my juniors to bravely use almost the same dose for our short patients as well. I say it is easier to treat the hypotension and all the cardiovascular dynamics that come along with a slightly more larger dose than to treat inadequate pain. But I would like to actually highlight an issue that a lot of us may not be aware of. And as far back as 1991, Hartwell has actually found that the dose that we need for our patient does not correlate with patient height. In fact, what he pointed out is it correlates more with vertebral column height from C7 to the iliac crest or to the sacral hiatus. And he tended to give a fairly standard dose of about 12 milligrams. And this is actually a very important graph of sitting height versus height ratio. Well, I have actually to share this in further details with you. I may, to a lot of you who know me, look like a very tall girl. However, I have a sister who is about an inch or so taller than me. And we used at one stage to share a car. And each time after I have driven, she will complain that I have moved my seat, the driving seat, nearer to the steering wheel. And I will always get a scolding from her. She says, you are going to risk having a chest damage if you suddenly stop by driving so near the steering wheel. Then my complaint would be, but I can't reach those pedals with my legs. So it has always been at the back of my mind why this is so. So when this study was brought to my attention, I decided to explore, and I realized that my legs are shorter than my sister's, and that's why by that 2 centimeters or so, and that would account for our difference in height. And if you look at a child as they mature, you will find that the sitting height against the total height actually drops down, and some people drop down into this range, and my sister actually drops in this range. So tall children tend to have long legs, and short children tend to have relatively short legs. In fact, what you should do is you should ask your providers. In fact, if you want to check on this, go back to your operating theater one day after the pandemic, get hold of a short provider and get hold of a tall provider. Ask them to put their iliac crest or put their hands akimbo on the iliac crest, and then equalize the two providers so that their iliac crests are at the same height. You'll be surprised that the vertebral height is actually the same. So my advice to all of you, don't treat short people as if their vertebral height should receive lesser drugs. Probably not so. They may have shorter legs, and that should not be a factor in the amount of drugs you put into the patient. Go on and use fairly standard dose. Don't reduce the dose because you risk having a failed spinal with an inadequate dose on that account. So while that particular study was dated in 1991, a similar or near similar study was made in 2017 from Taiwan. And here again, you will see that it is significant. Two factors are significant. Abdominal girth and vertebral column length again was emphasized as being important parameters to consider when determining the dose of drugs needed by the patient. So I would emphasize again, don't use too little drugs or don't reduce your drugs too much for the shorter patient. And because we are using heavy bupivacaine, for those of us who are sitting our patient up, waste no time in lying the patient down, because when you continue to sit the patient up, you will find that a large amount of the drugs will be going into the sacral level and not enough will be reaching upwards to give you the spread that you need. Now, of course, there's this question of obesity that has been raised by our two previous speakers as well. It is a challenge. And we also have challenges like this, where the spine is curved in kyphoscoliotic patients. So how do you go about improving your outcome? Obviously, all of us have to take up the challenge of learning how to do ultrasound, not for the difficult spine initially, for the normal spine. In fact, I myself have joined programs, teaching programs or learning programs, have failed in 2 programs until I decided that I have to learn and do the 60 or whatever numbers that are needed that Alexia mentioned in order to improve your technique. You really have to do those homework of subjecting yourself to the learning curve. obviously, now I'm very good at it, good enough to be able to teach my junior providers how to sort out their difficult spine. And it is actually very, very comforting when you're able to do in those patients just using the ultrasound to locate the spine for those with high BMIs in the 60s. So obviously you have to know what the pattern looks like in the longitudinal paramedian as well as the transverse view, both at the both where the spine is as well as between the two spinous processes and what it looks like and how to actually draw it. Now, the important thing also when you start your providers on this ultrasound course, it is very important to make sure they know the anatomy. I find it very amusing when I actually subject my trainees to draw the spine for me with the spinal cord and everything inside. And I have had many telling me the spinal cord is actually in front of the vertebral body. Then I say, well, what would the surgeons be able to find if they actually reach from anteriorly? Would they be able to find the spinal cord there? So actually, as I said, you'll be surprised. Our mind map of what we are actually doing is quite faulty, and it's time that we make sure that is corrected in order to improve. And if we actually are unfortunate to have the kyphoscoliotic patient, we have to be mindful that there is some degree of rotation added to the burden as well. So when that rotation occurs, the spine is now no longer going to be in the midline, but it's going to be rotated in the other direction. So your spinal has to then follow this part and come in from the lateral side. Once you're able to figure out, as I said, with a mind map of where the spine is, where the intrathecal space is, where you are in terms of where the tip or the outlet of that particular area where you're going to inject the drug is, you will find it is not so difficult after all. So in summary, for a lot of us, there is actually a lot of room for improvement. I have focused on improving myself for the last 15 years, have had many wonderful experiences learning, and have stopped blaming AstraZeneca or now Aspen. No more letters from me for that in that department. Of course, correct curvature of the spine actually helps. You must at all times ensure free flow. Flow out is just no good. It has to be extremely poor, extremely free. And the aspiration must be extremely good as well. If there's any doubt, push it back after the stellate has been put in, push it back and come out slowly again. If you have been in partially, you have got every chance of doing it successfully by pushing it back again. Ensure needle is in and stays in the intrathecal space during injection so that you do not allow any of the drugs you intend for the intrathecal space to escape into any other space. And do know the baricity of your drug, and that will help refine your technique and help to explain why the patient is behaving the way she does. Ultrasound can definitely help, and please invest the time to actually learn the technique and know all the pitfalls that come without knowing it, as well as the pitfalls that come with the use of it. All right, it can definitely help with the difficult spine. I have got juniors giving me aha moments and say, my God, it's so easy. We mark the area and they just go one shot, and they're so pleased with the fact that they have put in the time and effort to learn. So I would like to say terima kasih to all the organizers, and we are actually looking at 2 lives. So I'm actually urging all of you to do something right for them at all times. They must never share pain. They must never have pain, as all the 3 speakers have alluded to, And it's very important to understand that, because pain in the patient is not an acceptable entity. And if you think that you are not going to do something, you might definitely be sued and be counted in that 11% of obstetric claims against you. Thank you very much. And my email is here. If you choose to communicate with me, I'm more than happy to share my slides as well.
Thank you very much, Dr. Chan Kuen, for your information. Dr. Chan Kuen gave us a lot of information about especially about the changes of spine anatomy in pregnant women, position approach, sitting, left lateral or right lateral, specific spreading of the drugs, and also we must knowing the pharmacokinetic of the drugs, and of course, if possible, using ultrasound guiding to have a precise block. So, ladies and gentlemen, especially for our speakers, we are coming for the next session for the question and answer. And we still have 30 minutes for the sessions, but I saw in the chat a lot of questions from the audience. Maybe choose a few of that for the answer from the all speakers. Okay, maybe first question maybe can answer by all the speakers, maybe, I don't know. The first question, how do I avoid injury with the car in the combined block? Very frequent patient report paresthesia, even with gentle needle incision. Maybe first, Dr. Brendan.
It is common for them to feel the needle insertion. It's not probably paresthesia, it's probably the going through the dura, that little pop. So initially you would tent it and then you pop through it. It's brief and it's harmless. I warn patients they may feel something before, so they're aware to feel it. In terms of reducing the paresthesia of the epidural catheter, what I generally do is I bolus some saline that's remaining in my loss-resistant syringe. And that's been shown to push any nerves that are close to the tui away, so you can insert it with less paresthesia, less pain, and actually decrease some epidural vein cannulation doing that technique.
Okay. Thank you, Dr. Bernard. Dr. Alexa, any comment?
Yes, thanks very much, Dr. Mahdi. I agree. I think it's not uncommon for a patient to experience a sensation, right? However, I think for paresthesia, it's not so common. We're talking about shooting pain and all that, and I agree. I think if we do it more while using a midline approach, that might reduce the risk. And even if the patient reports some degree of sensation, I would do like what Brendan does, inject a little bit of a saline to not just to spread the nerve around or to push the nerve away, but to ensure that that sensation does not continue. And if it does, then I will be more concerned. But most of the time, I don't think I've experienced one that has a long-term sort of sequelae as a result of that sensation. Thanks very much. Back to you, Dr. Mahdi.
Thank you, Dr. Alexia. Maybe Dr. Chan Kuen, any comment?
Yeah, I actually have experienced paresthesia myself, not as part of an epidural or spinal, but right into my cubital fossa when an obstetric medical officer was trying to take blood from there. What she did was she must have hit the nerve there, on both sides. In fact, when I yelled out in pain, she stopped and then she went on to the other side. And again, she hit my nerve and I yelled out in pain. Now, that was not the end of the story. Obviously, I had blood taken subsequently by my anesthetic medical officer, but I went home and had to suffer the tragedy. Remember, it was just blood taking with a needle of 18 gauge. And here, both my nerves were hit. And I suffered the paresthesia, the painful paresthesia, or some kind of funny numbness feeling whenever I moved my hands. And that was for about 2 to 3 weeks. I had to actually ask my colleagues, what shall I do with it? Do I need to do anything at all? There's nothing, just time will heal. But do remember, patients do complain. They do suffer in our hands when we hit the nerves.
Thank you very much, Dr. Kuen. So another question that from Fahmi Agnesa to all the speakers. Do you have experience using liposomal bupivacaine or neuraxial labor analgesia? The second, what do you think using small catheter for continuous spinal analgesia in labor? Maybe begin from Dr. Brendan, maybe?
Yes, sir. I didn't catch the first question. I heard the small catheter for spinal, so I'll answer that one at least. There are some products out there that allow you to do continuous spinal analgesia or anesthesia. Obviously, the microcatheters got pulled off the market because of some neurological related concerns, probably because of pooling of local anesthetic around certain nerve roots. The difficulty is always balancing the increased risk of post-dural puncture headache with the analgesic efficacy you get. And also, surprisingly, continuous spinal labor analgesia doesn't work as well as you think it would. You get firstly tachyphylaxis, so it works for a while and stops working. But also you have quite a high failure rate despite being in the intrathecal space. So it's a technique we do not use at all. If you were to have an accidental dural puncture, then we do, in advanced labor, select to insert the catheter and use it. We would do the same intraoperatively with, in other words, the macro catheter, your normal epidural catheter. And I'm sorry, I didn't hear the first question, but you can maybe give it to someone else.
Thank you, Dr. Brendan. And Dr. Alexia, maybe?
Yes, I think Brandon will be able to answer the first question. It's on the use of liposomal bupivacaine. I think you have published some work on that.
Yes.
I personally haven't, but back to the second question. Again, I have no experience in using a small continuous spinal anesthesia catheter, but we have just recently published a review article on the use of intrathecal catheter for labor analgesia, and it is largely because of the accidental dural puncture. So I maybe you want to refer to the article. Yeah, thanks a lot. Back to you, Dr. Madhu.
Yeah, so I mean, to answer the liposomal bupivacaine, we have no experience. We've used liposomal morphine, so the extended release epidural morphine, and that was for epidural administration. Actually, wasn't licensed for spinal. The development of liposomal bupivacaine was not for intrathecal administration. There have been some accidental administrations that I am aware of. And it didn't seem to behave much differently to normal bupivacaine, but it's not something we have experience with.
Thank you, Dr. Brendan. And maybe Dr. Chan Kuen?
I have got absolutely no experience with liposomal bupivacaine, but you were talking about cutting spinals, the needle, as well as a smaller gauge. Yes, I do realize that a lot of us tend to go for smaller, I mean, not the catheters, but just the needle itself, tend to go for smaller gauge with the idea that you would be able to reduce the risk of spinal headache. But a lot of us, however, again, do not realize that any needle is like a knife. It can cause a lot of damage depending on how the provider uses it. So, I mean, you can make a gentle cut or you can make a slash as well. Similarly with a spinal needle. If there is movement in the patient, your 25 gauge may actually create a hole that usually would be created by your 18 gauge or even 16 gauge. Similarly, your 27 gauge is not so easy to insert, and you will probably be making quite a number of attempts sometimes, and you don't get the free flow that we talk about, so difficult to aspirate, and you tend to actually add more attempts, and you may create a bigger hole than you realize, and it doesn't really solve the problem of reducing spinal headache under those kind of circumstances. So we have to understand our technique all the time. The studies that obviously we have done are done under very controlled situation, but what happens in the front line, as I said, a lot of us are not aware.
Thank you.
Dr. Madi, if I may make a comment on the use of spinal needle. Yes. So I think there's overwhelming evidence to suggest that the use of a pencil point needle actually results in a lower incidence of spinal headache. Initially, the thought was that one was cutting and the other was not cutting; it was just separating the needle. But I think there's histological evidence to suggest that the reason why a pencil point needle results in a lower incidence of headache is because of the fact that it's not sharp, as a result of which there's a fair bit of inflammation, as a result of which there's that thing that seals up the dural rent. So I think the recommendation is, if possible, I think for the same size. Of course, there will always be exceptions to use a pencil point non-cutting needle. Thank you very much, Dr.
Thank you, Dr. So another question, we will talk about lidocaine, because you know that in Indonesia, we still use lidocaine, especially in the rural area. So the question from Ahyar, just a moment, from Ahyar. Okay, just a moment. From Dr. Ahyar Unud. Is it possible to use lidocaine in labor analgesia? If possible, at what concentration can be given? Okay, maybe comment from Dr. Brennan first, maybe. You still use lidocaine?
Yeah, so I'm gathering you're asking for epidural administration. So we certainly do. We don't do a test dose. We utilize our normal solution as a test dose, and we look at analgesic effects to see if it's working. The problem with lidocaine is it does give more motor block than bupivacaine. So we generally would reserve it for patients who are very advanced. So the baby's going to deliver soon, and you really need the onset for those purposes. We try not to use more than 1% because of the concern of motor block and inability to push. We certainly use lidocaine for top-ups for cesareans, and we would do 2% with epi as our standard top-up. So yes, we do use it. And I'm not aware of the same concerns when you give it epidurally compared to spinally in terms of transient neurological syndrome or neurological issues.
Okay. Thank you, Dr. Benan. Dr. Alexia, any comment?
So, Dr. Madi, just to clarify, the use of lidocaine for epidural and
yes, epidural and spinal also.
Okay, so we don't use spinal lidocaine for obvious reasons, but for epidural we do use it. In fact, it is the drug of choice for us when we top up the epidurals for cesarean section. In the delivery suite, I think the practice varies, but increasingly I think there's a tendency towards using the more long-acting drugs. So in our institution, the sort of the default drug is ropivacaine, and like what not dissimilar to what Brandon talked about, we use 0.1% ropivacaine with fentanyl. We don't use sufentanil, 2 mics per mil, and we typically run it 10 mils per hour or intermittent 5 mils or 10 mils depending on practice. I think there's belief that and there's evidence as well to support the use of higher PIB doses in the maintenance of epidural analgesia. So typically 8 mils per hour. I think that would be our recommendation. But we do use a higher concentration for top-ups, bupivacaine 0.2%, for example, especially towards the second stage of labor.
Yeah.
And I'm aware that some of our doctors also use lidocaine, but definitely not more than the 2% for the top-ups in epidural, for epidural analgesia. But I think that's the minority, but almost never more than 10 mils if that happens. Back to you, Dr. Madi. Thank you.
Yes, you know that in Indonesia we still have 5% lidocaine for spinal and 2% lidocaine for epidural, like that. Okay, Dr. Chan Kuen, any comment for that lidocaine?
Well, long time ago, that's very long,
Yeah,
quite
yeah,
old, you know. We used to, of course, use 5% heavy lidocaine. And when it was taken out of the market, I remember reading another editorial or comment that says that even the 2% you have to be very careful in the intrathecal space.
Yeah.
So on my own, when I look at it from a very philosophical point of view, I always tell myself I'll never touch lidocaine, even if it is to top up for an epidural, because I always tell myself we've got to try to control the situation. And a lot of us, when the epidurals don't work early enough for the seizures, for example, if we are topping up, we have only ourselves to blame for not being, for not anticipating when the patient needed to top up in anticipation for the seizure. And I don't really think that few minutes does make so much difference, being mindful of the effects that some of the lidocaine might actually travel into the intrathecal space as well.
Thank you. Maybe one question more for Dr. Brendan. The question is, does epidural needle tip direction during cardiac advancement caudal rather than cephalar can improve sacral sparing, Dr. Brendan?
Yeah, so I'm not aware of studies that have compared that. We generally place the TUI with the bevel up and thread it. I think with flexible catheters, which I strongly recommend, in fact, I can't believe we even have stiff catheters anymore. Flexible catheters are quite remarkable. It's essentially eliminated our one-sided placements, or it's a lot less common, less paresthesia, less epidural vein cannulation. So I don't think it makes much difference with the flexible catheters. I think they move around a lot. But I'm not aware of a study comparing deliberately caudal versus cephalad insertion. I don't know if the other speakers are aware.
Okay. Because of time is up.
Can I just make a comment on the sacral?
Please.
Actually, a lot of our junior providers as well don't realize that there are two parts to the pain: the abdominal pain, which is covered by T10 to L1, and the sacral pain, S2, 3, 4. Now, a lot of us, when we infuse our patient, there are some patients who prefer to be almost nearly horizontal, lying flat. There are patients who prefer to be topped up or continue in having the infusion upright. So depending on the position, sometimes those upright positioned patients may actually, because the drugs are mainly infusing right into the sacral area, they may actually now not have enough drugs up in the epidural space covering the T10 to L1, and they will complain of pain there. And whenever these providers see the patient, they don't ask where the pain is properly, and they just top up. I don't know how, but by right, if you top up to cover that area, you lie the patient down, and the drug should go to cover the T10 to L1. Similarly, towards the end, a lot of patients do have sacral pain, and I have on many occasions topped up in this sitting up position to eliminate those pains. So I think it is very important to be mindful of that part. Mindful of the fact that obviously my two other speakers would never have epidurals for labor when I myself have been, I've experienced 4 epidurals although I have only 2 babies, but it is very important that you have to really experience it to know what it's all about.
Okay, thank you once again. Time is up. On behalf of the Indonesia Organizing Committee, we would like to express our grateful thanks to all the speakers, Dr. Brendan, Dr. Alexia, Dr. Chan Yu Kuen, and all the participants. Thank you very much. Thank you for the Bro Susilo, my friend, my best friends, Dr. Eddie, and silakan Dr. Ani mari saya kembalikan ke MC. Terima kasih banyak. See you later.
Terima kasih.
See you later.
Thank you.
Please don't leave.
Oh,
Alex, Brendan, and because after this I will play music for you. Okay, good.
I would like to thank Prof. Made for guiding these sessions very well. Thank you for all 3 speakers. Thank you, Brandon, for staying awake. What time is it?
Not so late, sorry.
Not so late.
It's almost tomorrow.
Yeah.
Thank you, Dr. Alexia. Thank you, Dr. Chan Yu.
Bye-bye.
Still some questions in the Q&A box. If you are willing, you can type the answers for some of the attendees, if you want to answer questions.
Still a lot of questions. 21 questions.
Many questions in the field of obstetric anesthesia, but I think 3 of you already explained all the basics. Also, the advancement of the obstetric anesthesia very well, very good. All right.
Alex.
Yeah, bro.
Yes.
Hello.
Yes. Okay.
Thank you.
Already
Thank you,
mentioned,
everybody. Okay.
we will have the music break in a few minutes. I think Dr. Susilo is getting ready.
Okay.
I think some of the musics will be specially made for Dr. Brendan, Alexia, and Chan Yu.